Welcome back to another episode of Carilion Clinic Antimicrobial Stewardship Podcast, where we will continue the conversation about topical infectious diseases issues. This is a podcast that is by medical professionals for medical professionals. I am this episode's host, Nick Stornelli, a board-certified infectious diseases pharmacist here at Carilion Clinic. I am joined by an all-star ensemble of interdisciplinary providers, including Carilion Clinic's very own Dr. Bansal, Dr. Ambroz, and Dr. Fidler, and I will let them introduce themselves for today's episode.
Hey, so I'm Chelsea Ambroz. I'm a board-certified family physician. I've been in Roanoke since 2017, and I've practiced at two different locations in Southeast and off of Colonial Avenue. As a primary care physician, I recognize I see a lot of complex chronic conditions, and I really have found over the years I enjoy the primary education, lifestyle modification, and the pharmacological management of diabetic care. I'm also married to a vascular surgeon, so at home we have a lot of lively conversations about all things medicine, including diabetic foot infections and limb preservation. My husband often remarks that if my job is done well, then everyone else listening and contributing to this podcast would have a much lighter load at work. So anyways, I'm honored to be here.
Hi, I'm Ekta Bansal. I'm one of the ID physicians at Carilion Clinic. I have been practicing infectious diseases since 2011, and diabetic foot infections is very close to my heart and talking about it. And diabetic foot infection remains, the most common cause of the complication in the diabetic patients. So from my prior experience and my family members having the diabetes, this topic remains very close to my heart. Thank you for having me here today.
Fidler. I'm a podiatrist with the group, with the Carilion, and I've been with Carilion about 9 years now, and we obviously do a lot of diabetic foot infections and amputations, hundreds a year, just myself. So unfortunately, it's a huge problem. It's everywhere in the country, but we see a lot of it. My specialty, I did my residency training at Georgetown University, which has one of the top diabetic limb salvage programs in the world. And a lot of the research referenced in this article comes out of there and out of some of their colleagues. And so we work a lot together with infectious disease and vascular surgery, and obviously our internal medicine doctors. So happy to talk about something that takes up a lot of my time.
It's super exciting to have everyone here today to talk about this topic. So we'll be diving into diabetic foot infections for today's podcast. As everyone is likely aware, that providers in Carilion Clinic have likely touched or seen a patient that either the goal is to prevent complications of diabetic foot infections or to manage them. And so we have all of the members here that on either end of the preventive or management spectrum have solid experience in that sphere. And very timely for this podcast because of new guidelines in the infectious diseases world, which are few and far between. That's about every decade that we get new IDSA guidelines. And so there's some recent combined IDSA and International Working Group on Diabetic Foot, IWGDF. It's the first time that we've seen combinatory guidelines like that for a unified treatment and prevention and management approach. So the focus of today will be on diagnosis and management, mainly for outpatient providers, but there will be elements that touch on the preventative screening process as well that are very important. To kind of head off the conversation, I definitely want to jump into some of the background on the diabetic foot infections that we see. And I want to point to our infectious diseases provider, Dr. Bansal, and just give us an overview of how do diabetic foot infections develop and really what is the spectrum of disease that we can expect to see for this entity.
Certainly. So infections of the skin and the soft tissues of the foot in a person with diabetes most often follow a break or a breach in the protective skin barrier. This breach is known as diabetic foot ulcer, which involves usually the most superficial layers of the skin. The complication or the diabetic foot ulcer happens most often in the settings of those patients who have peripheral neuropathy and frequently associated with peripheral arterial disease. And this combination or this complication makes them more susceptible to having a minor trauma, and that goes unnoticed. That leads to the formation or the beginning of the ulcer. So once the ulcer is formed, infection usually follows. What happens initially is that the wound gets colonized by complex microbiological flora that usually lives on the skin. And this presence of the bacteria on the wound surface does not necessarily mean that that's infection. It just means that the wound is colonized by the presence of the bacteria. If there is invasion of the foot tissues by the bacteria, that's what we call as diabetic foot infection. And that usually starts an inflammatory response by the host. And that inflammatory response leads to the tissue damage and leads to the complications such as wound infections, and which can range from superficial cellulitis to deeper layers, turn to go form abscess, and even deeper down to the bone, which is known as osteomyelitis.
Yeah, I think you point out a really great point about diabetic foot ulcers as a complication of diabetes. And, the ulcers are seemingly quite common. So you point out the need for discerning clinical infection from a non-infected ulcer. And in preparation for this discussion today, I was looking at what does the newer literature kind of suggest. Ulcers are quite common amongst our diabetics. About a third of those, it seems, end up, within their lifetime, end up becoming infected at some point, which I think represents an increase from some of the literature in the 90s that was about 15 or so percentage of patients. So certainly the problem is not going away, and it points to like the issues with the primary care scene of preventing these from happening. And what, from Dr. Ambroz's opinion, what strikes you as some of the most difficult areas to address for the infection or just the nature of anything surrounding this disease?
So not only are diabetic foot infections difficult to diagnose, but once identified, it requires stellar glucose control, proper wound care, selecting the correct antimicrobial regimen, and sometimes a surgical intervention. I recognized in my practice that managing diabetic foot infections is multidisciplinary: primary care, endocrinology, wound care, podiatry, vascular surgery, and infectious disease specialists all often have to weigh in. Coordinating the care can be complex, and I've found that delays, lapses in treatment can really progress the poor outcomes that can occur. Some of my patients in particular, really struggle with their diabetic management, and they have limited access to resources, whether it is medications or transportation or just many of the things that are involved with managing their chronic disease. And it's just a really challenging cycle for them. Even in the perfect setting with all the necessary resources, I found in practice that sometimes something as simple as a missed appointment due to a transportation barrier can spiral into delayed care for weeks or months, as it's hard to reschedule. And then a simple infection can turn into cellulitis, abscess, or osteomyelitis, increasing the risk of hospitalization. And we now know that diabetic foot infections are the leading cause of hospitalization for diabetic-related complications.
Yeah, that's a very difficult entity, especially in the preventative part, right? And often you're seeing patients that already have ulcers that are there. How, in your practice, Dr. Ambroz, what does your initial assessment look like when you have either suspicion or even just from the screening of an active ulcer or patients that are having poor glycemic control? Walk us through just what are some things that point you to suspecting diabetic foot infections?
So knowing that patients with diabetes and vascular compromise are at an elevated risk of developing diabetic foot infections, I make it a practice to regularly complete foot examinations of my diabetic patients. I tell my nurse if they're coming in for a diabetic follow-up, they should have their socks and shoes off, readily available so that I can assess their lower extremities. I recognize that many of my diabetic patients, just as Dr. Bansal was saying, have peripheral neuropathy, which of course increases their risk, but they might not even realize they have a foot infection in the first place. So my assessment of the diabetic patient starts before even entering the room. I review the vitals before entry just to see if there's any signs of systemic illness like elevation or changes in their temperature, their heart rate, respiratory rate. Because if anything is out of the normal, I know I'll be looking a little bit closer at the patient behind the door. In the primary care setting, I typically don't have access to looking at other white blood cell counts or inflammatory markers until at least 24 hours after the initial patient visit. So I really have to gather and utilize my physical exam. I typically, as I said, request that they have their socks and shoes off, and then systematically every visit I go through the same steps just to make sure I don't miss anything. So observation from across the room and then up close, inspection, palpation, and sometimes auscultation with a Doppler if necessary. On exam, I look first for signs of infection. I need to know, is there any erythema, any tenderness to palpation, warmth, swelling, or purulent drainage? I check for ulcers or blisters and inspect between the toes, which often have surprising findings, and the bottom of the feet and the heels. I look for ingrown nails, fungal infections, trauma to the nails. I also look for calluses and corns, thickening of the skin, which could be an indication of pressure points. And I have found that a lot of my patients have very chronically dry skin, which can increase their risk for infection. And I verbalize with my patients any findings as I'm going along the way because they might not be aware of what I'm finding. And then, of course, very important is to check their pulses, to look at the color of the skin, to see if that increases my suspicion that maybe they have undiagnosed PAD, and use the monofilament to check sensation. My nurse actually bought me a thing of fishing line because she felt like it was more cost effective for our clinic. So they joke that I'm bringing out my fishing line again.
I love that approach. Conventional approach to assessing patients' awareness of the bottom of their feet, and it's a really great point because of how all the complications of diabetes, neuropathy, the unawareness is sometimes I would imagine very shocking to patients when you tell them that there's the ulcer has grown or it looks large or it looks angry and they're not showing constitutional signs. Turning over to Dr. Fidler, if there is that infection that is present, the guidelines, this iteration and the prior IDSA iterations always kind of have their classification of severity. I definitely want to hear your opinion on how you like to approach severity assessment, engaging what the next steps are going to be from a podiatry angle.
Yeah, I guess, there's kind of two ways to look at it. So, if they're coming to me in the office or in the wound center, then we may not have labs and everything that we can immediately check. But like Dr. Ambroz was talking, the clinical signs of increased redness, swelling, pain when they normally don't have pain. So even though a lot of these people have profound peripheral neuropathy, a lot of times when they have an infection, they'll feel something, and usually they may feel some extra pressure in there or whatnot. But obviously you're looking for any sort of streaking up the leg or anything that might make you think that this is more severe and you might need to get them over to the hospital. A lot of times people will think that it's an infected diabetic foot ulcer, and it really just needs a good cleaning and debriding the callus and stuff. And then you look at it and it's actually very healthy. And so that's a very common thing. There's all sorts of classification systems. I mean, in school, we learned probably 20 of them trying to figure out how to assess diabetic wounds. But for the most part, the presence of infection, so purulent drainage, and then probably the probe to bone test are definite. You got to get them in the hospital for some sort of IND debridement, whether it's bedside or in the OR, depending on how severe it is. But even if you don't have a bone sticking out of the bottom of the foot, if there's exposed tendon, things like that, those can be very risky because those tendons to the toes, they track up the foot and up the leg, and you can get pretty quick spread of infection in somebody that has either macro or microvessel disease. So, pretty much all these with the polyneuropathy, they have microvessel disease, and they're not getting good perfusion to the tissues themselves. And so I know they talked about the PETA score here, just kind of looking at different ways of doing this. For the most part, we're looking for the depth of the wound itself. And then also the other medical comorbidities they have are going to kind of make us be more concerned or less concerned. But certainly labs, basic x-rays, things you can do in the office are a good starting point. And then really just trying to decide whether these people need to go to the hospital or not. And again, most of the people that have ended up with an amputation, they don't just have diabetes. It usually have some sort of vascular disease, whether it's cardiac or peripheral vascular disease. They've got chronic kidney disease. They might be smokers. Just overall health is probably not where it could be. So kind of the risk stratification is definitely going to be more important for the people that are going to be at high risk. And I think peripheral arterial disease certainly is one of the biggest risk factors for these.
Yeah. And in those patients where we are kind of thinking more of a severe infection, moderate to severe, you mentioned a little bit about grabbing some labs on patients. And, this is not just an antimicrobial stewardship podcast, but we also care about how we're using our laboratory resources as well. What in your mind are the most appropriate initial labs for a patient, newly suspected diabetic foot infection? What are you grabbing on those patients?
If it's a consult in the ER, we're going to get, kind of standard CBC with diff and BMP, maybe an A1C, just to kind of get an idea, are they well controlled? And really that's more, if their A1C is 15, chances are this is going to be challenging to control, because they might have a blood sugar of 500, but if their A1C is 5 or 6, then okay, that's probably just due to the infection. But if they're chronically living at that, then their chance of fighting this off is going to be pretty challenging. Then we usually get ESR, CRP, and kind of can go off that.
That's super helpful insight for, primary care physicians, providers that are maybe thinking their patients heading towards needing to be, admitted to have further investigation of a deeper seated infection. That certainly kind of touches on some of the point about, the new guidelines that came out. They do have a lot of that incorporated into the recommendations for lab work. Dr. Bansal, what in your mind are lab tests that maybe we should forego or no longer recommended, or prior dogma that is no longer a component of current practice that we should dissuade use of?
So there are many wide arrays of the testings available, as mentioned by Dr. Fidler, many blood tests, culture methods, imagings. There are couple that we do not recommend, or the studies haven't shown their efficacy or utility. So those include foot temperature, photographic foot imaging, and infrared thermography. So studies have examined their value in predicting the diabetic foot infection or the clinical outcomes, but overall, they do not appear to provide substantial, meaningful information in either the diagnosis or the clinical outcome, especially in the hospital settings. So while infrared imaging likely causes no harm, its utility is really limited by its lower sensitivity, specificity, and lower availability as well. We no longer suggest using qualitative microbial analysis as the methods for diagnosing diabetic foot infections anymore. There have been studies where people have advocated the presence of the higher numbers of the bacteria on the culture as a basis for differentiating infected from the colonized wounds. However, there is no convincing data that supports this concept. Patients could be receiving the antibiotics at the time of the initial wound cultures. So that bacterial content could not be the real bioburden they are carrying. For the molecular methods, the problem is that they tend to over capture the bacteria. Some of those bacteria, which may not be causing the infection, could be captured by these very sensitive techniques. The things that we do not know from these molecular methods is if the bacteria are alive or dead. So we may be just capturing the dead bacteria and treating them with the antibiotics when they are not needed. But it's something that is under the studies, and we'll have more information with the time.
Yeah, and I think this is an excellent time to really dive into, diabetic foot infection is such a large umbrella entity, and kind of segue into talking about the kind of spectrum of infection. So, thinking of soft tissue infection, Dr. Bansal, you talked about organisms and identifying bioburden and culturing. Now we're getting into like how to identify what we're actually treating. How do we identify pathogens, or what is the best practice for isolating where soft tissue alone is suspected? How do we isolate our organisms or know what we're treating?
Yeah, so in general, we try to obtain a sample for the culture that helps us identify the pathogens for the diabetic foot infection. And what is the best specimen to culture? So generally, we discourage obtaining a wound swab because it can grow not just the pathogens, but also the wound colonizers or the contaminants, and that does not generally represent or tell us what are the pathogenic bacteria causing the infection. So what is preferred is a tissue specimen by either a biopsy or curettage or during debridement. Those specimens would be more ideal for the culture.
Yeah, and I can imagine we even more milder infections as well. I think a great point of culture, getting good deep cultures when a good deep culture is needed. We often see maybe just some local cutaneous infections, and I'm sure Dr. Ambroz has some insight into like when is it the right time to just skip culturing when in the right instance, and when is it right to provide just mild soft tissue infection coverage in these settings?
I think it's helpful to look at the criteria for mild soft tissue infections. If the infection has greater than 2 signs of infection, such as induration, erythema, tenderness, warmth, or pus, but does not have signs of systemic manifestation, and the erythema does not extend beyond 2 centimeters around the wound, then you can skip the tissue culture. So luckily, these are the types of infections that I see in my clinic. Typically, these patients have not had recent antibiotics and do not have risk factors for drug resistance on prior culture results. So those would be the patients that would benefit from skipping the tissue culture.
Yeah, and I'm sure like the most uncomplicated infections are still very burdensome to patients. And you point out like even getting cultures, like to get a good culture, it requires more interrogation and deeper, often using a curette or something during debridement. Dr. Fidler mentioned the probe to bone test, and I definitely want to get some insight into when our frontline primary care providers should really be looking to use that as a tool. Like when is the right time to deploy probe to bone? Should it be like all of our patients with open ulcers that look deep, or is there any more kind of discrete details as to when that test is indicated?
Yeah, I mean that's a good question because it's always good to look at the wound and probe it, because a lot of these will have undermining, and sometimes that tunneling can just be from some new callus forming over the wound, which is super common, and it doesn't go anywhere. But occasionally there can be just a little pinhole that actually tracks up into the bone itself. So sometimes that can be challenging depending on where it is. Other times it's obvious the bone's sticking out, and you can technically you should use a metal probe, but not many people have sterile metal probes in their office. So a Q-tip gets used often. Just try not to break it off in there. That's one other thing we have to cut out later on. And I've done that myself, so I'm not blaming anybody. But, sticking a wound in there, and if you feel the bone and it's bone, which is the other thing, it can be easy if it's, right on the side of the big toe and that's it. But coming in from the bottom of the foot, there's a lot of different tissues in there. Some may feel harder. It may just be the capsule as opposed to the bone, but it can feel. So for the most part, that's something that when they're in the ER and they consult our team, that's, one of the things that our residents always do, we always do. And for the most part, it's pretty sensitive to osteomyelitis. 80% and up. Some have said 90%. I think the duration of how long that wound has been that deep plays a factor as well. If it just opened up yesterday, that's going to be different than a wound that's been probing the bone for 3 months. It can definitely be part of the test, but it's not the only one you do. Obviously, you're going to look at x-rays, and if you've got a positive probe to bone test, but x-rays don't show any sign of cortical erosion or destruction, then you can kind of take that into account as you're making a decision on whether this person needs an aggressive surgery or maybe they just need some IV antibiotics and try to take care of the soft tissue infection. That's easy when the bone is hard, but in some of these older patients that have osteopenic bone, it can be very challenging, even when we're looking at it, between what is infected bone versus what is healthy bone, because normally bone's very hard and it's hard to cut with your hand, but in some patients with significant osteopenia, you can almost squeeze the bone and squish it with your fingers, which is what normal infected bone would be like. So kind of using all of them in combination is important.
Yeah, and you mentioned like different bone types and squishy bone versus hard bone and infected versus non-infected bone. When does biopsy or bone biopsy or other imaging modalities kind of come into play when you just have positive probe to bone?
It depends. It depends on a couple things. Depends on the location of the bone, which one is involved. There's certain ones that are not, you can't amputate or you can't cut out without causing a significant deformity or a essentially non-functional foot. So like for heel ulcers are the most dangerous we see because, if you have a positive probe to bone in the heel, you can't just remove the heel bone because then it's going to be non-functional limb and you may as well go for an amputation. So, there's certain roles for that. Also, the fifth metatarsal is another one where you can't remove the entire fifth metatarsal or the foot will just continue to turn an eversion because of the attachment of the peroneal tendons at the base of the fifth. So that's another one where bone biopsies are very important because it's not going to be a surgical cure where we can just cut out the infected bone, which also kind of brings up the other side of this whole discussion, which is treating osteomyelitis from a surgical standpoint, which surgeons, we have our own opinion, and then non-surgeons have their opinion. And I think the correct answer is somewhere in the middle. I think surgery is not indicated for everything, but there are some instances where you kind of have to cut away that bone. A bone biopsy certainly is very important, but even that is not definitive. There's studies out there showing the inner reliability between different pathologists is upwards of 40-50% accurate. And there have been a couple studies showing that. And so if you can imagine, we're sending, a bone biopsy to the lab and they say that's infection, and then we're cutting toes off because of that. That doesn't make me feel, warm and fuzzy when 50% of them can't even agree on the same diagnosis. So, a while ago, we started sending bone for permanent specimen and also bone for culture, put a little piece of bone in the culture tube. If they're both positive, then it's obvious that that's bone infection. If the bone pathology is negative and, then a positive bone culture, then it's infection. But if the culture is negative, you can't say, well, it's definitely not infected because they may have already been on antibiotics from either their outside provider or they have been on them in the hospital already, so you can get a false negative there. So it's definitely challenging. And when there's a significant soft tissue infection, a lot of times you don't necessarily want to wait until you can get them to the OR to get a good biopsy, because that tissue's dying in the meantime. So it certainly can be challenging. Also, if we cut bone with a saw, the thermal necrosis a lot of times looks like dead bone underneath the microscope. And so another thing that can muddy the waters when you're talking about getting a diagnosis of osteomyelitis from sending bone for specimen is the method in which you collect it. Ideally, you do it with an osteotome or something that doesn't kill the bone, but that's sometimes very challenging to get a good clean cut.
Yeah, I think that represents the incredible dilemma of diagnosing and classifying. In order to classify, you kind of have to get, the tissue is the issue. Sometimes that's not even feasible for, the morbidity aspect of what's the downstream effect of that management and surgical management. So I want to pivot a little bit to now, if this antimicrobial stewardship podcast, we need to talk about the antimicrobials a little bit. When we're talking about soft tissue infection, we have a variety of antimicrobials at our disposal on the outpatient side and inpatient side. How do we decide what we need to cover for our mild infections? And Dr. Ambroz, you see a lot of the mild infections in your practice, and I kind of want to hear your thoughts on walking through what are the organisms that we're looking for in some of the more mild cases, and what are you using in your repertoire of antibiotics?
So treating patients with diabetic-related foot infections should involve consideration of local antimicrobial sensitivities, severity of infection, patient factors like allergies, drug-drug interactions, and previous response to treatment. Assuming the patient has had no recent antibiotic exposure and is low risk for multi-drug resistant organisms, the guidelines recommend coverage for beta hemolytic strep and MSSA for mild infections. So typically, I utilize Keflex or Augmentin for 1 to 2 weeks. But this can be extended up to 4 weeks if symptoms are slow to resolve. If there is a history of MRSA in the mild soft tissue infection, then I go for doxycycline or Bactrim. Now, one thing I always think about is pseudomonal coverage. And really, not every diabetic should be offered pseudomonal coverage. In particular, those with mild infections, it's important to consider if they have risk factors, including prior tissue culture results or multiple recent antibiotics. I think that patients that have had recent admission or they're immunocompromised or even, live in warmer climates or the tropics have a higher risk and rates of Pseudomonas. But I'm not always covering my patients for this when treating the mild infections.
Yeah, and I really love the new iterations of the guidelines that they come out and state, do not empirically target Pseudomonas instead of having less straightforward verbiage. So really specific patient populations. The recent isolation of it is very important. Prior antimicrobial history, as they're concerned from a recently surgerized patient as a complication kind of external to just naturally the staph and strep that we typically see. We're here in Southwest Virginia, a temperate climate, so we're not dealing with moist, hot, heat, wet, dampness as some other areas. So it's not an empiric recommendation for most cases to target Pseudomonas. And particularly on the outpatient side is very important because there's very limited options that are available oral for pseudomonal coverage. You're thinking about your fluoroquinolones, which have higher odds of Clostridioides difficile infection, untoward adverse effect profiles, tendinopathy, QTC prolongation, the list goes on. So it's great to be thinking about what are the most likely assailants in these more mild infections, staph and strep. How, in turning the tide there in the spectrum of infection, more sicker patients that are, have had maybe multiple bouts of antibiotics or are appearing sicker, more severe complications or constitutional signs of infection. What is the approach? How does this change? What do we start to think about, Dr. Bansal, in terms of these patients in the outpatient setting that are maybe looking more worse or have developed fever or more kind of systemic signs of infection? What's the approach with antimicrobials in those cases?
So those patients definitely need to come to the hospital. Those who are having systemic signs of infection, meaning the infection is getting severe and spreading probably by bacteremia to the other parts of the body. So in such cases, having an urgent surgical consultation by the podiatry is recommended. Starting the broad spectrum empiric antibiotics early on is recommended. Usually, having a consultation by a vascular specialist as well to determine peripheral arterial disease severity is recommended. Patients with moderate to severe infections usually requires a multidisciplinary approach by the combination of medical and surgical treatments. So we have to look if the patient is hypotensive, febrile, obtain the blood cultures in those patients. As Dr. Fidler mentioned, if there is signs of the necrotizing infection, gangrene, or deeper abscesses, those patients would require a surgical intervention with washout and debridement. So some of these would be indicated in an earlier timeline for the patients who present to the hospital in a more severe infection.
I will just say one of the most dangerous situations is a diabetic foot infection in a patient with peripheral arterial disease. And if they have bad ischemia and the wound is black and necrotic, those are the limb-threatening ones, because not only is the body not going to be able to mount a defense, the red blood cells, everything's not going to be able to get their white blood cells to fight off the infection. Any antibiotics you're giving are not going to perfuse down there, because not only do they have microvascular disease, but they also have macrovascular disease. So in those instances, we always try to control the infection first, because infection trumps ischemia. We control infection, and then it's our vascular surgery colleagues to the rescue to try to give us some sort of improved perfusion, either endovascularly or through an open procedure, bypass, whatever it is. And then after the tissues demarcate, then we can go back in for either, a definitive level of amputation, or if they don't have enough perfusion to the foot, then a lot of times it's just, either a proximal amputation, or we just kind of let things ride. But yeah, we talk to the vascular guys on, if not half, at least a quarter of these infections, because so many of them that end up in the hospital have some sort of peripheral vascular disease. And so it's that team approach.
Yeah, and I think the highlight there that may change your management as far as our recommended durations of therapy. How does the surgical modality kind of alter or modify your approach to when we're talking about durations of therapy in these cases? Walk me through kind of what in your mind, changes.
Patients who get a good surgical source control, meaning the abscess was drained, the infected bone or the soft bone was resected and amputated, and the pathology shows that the bone margins from the amputated site are clear of infection, those patients could be managed with a shorter course of the antimicrobials. Typically, we would do somewhere between 1 to 3 weeks, depending on the patient's soft tissue infection burden and the extent of the systemic symptoms. However, if the bone wasn't able to be resected or debrided, and the bone osteomyelitis management we are pursuing, it typically goes for 6 weeks of the antimicrobials.
And what are you in your practice leaning on as far as antimicrobial regimens? Like, walk us through a little bit about are these patients, are they going to, if they have residual osteomyelitis, that positive path after debridement, are we going to give them all intravenous products? Is there a role for an intravenous to oral transition at some point? What in your practice is kind of the current state of affairs with regards to agent?
Yeah, so when prescribing antibiotic therapy for diabetic foot infections, we consider several issues. In particular, if the antibiotic is able to achieve a good enough serum level and then penetration to the bone. It is important to consider the bioavailability of the oral drugs. For example, people are able to absorb the antibiotic from an intact GI tract, If they have any underlying GI issues, then oral antibiotics would certainly be challenging in them. So then after the antibiotic is adequately absorbed into the blood, we need to be aware of if the antibiotic is able to adequately penetrate into the bone. Many classes of drugs are available in which there is a good bone penetration. There has been more recent randomized control studies that have come up showing good literature on how the oral antibiotic therapy can be used in these cases. So generally, we like to evaluate these patients in the beginning, depending on if they are bacteremic or not bacteremic, if surgery was done versus not done. The duration ends up somewhere between 3 to 6 weeks of the antibiotics. And we do not necessarily have to do IV in all those cases. After an initial lead of IV antibiotics, we do consider oral antibiotic switch in many cases and have been successful in treating many infections with oral antibiotics.
Yeah, music to my ears. I love the opportunity for that transition to take place, to get patients off of lines, give them a little bit more freedom to go about their active daily living tasks and not be tied to an IV pole, as well as, just after the management and being surgerized and spending time in the hospital. We have some really great literature that does support that transition, with adequate upfront response to therapy. Obviously, the theme of today's discussion has been multidisciplinary approach. So it does take a village to ensure, even if you have patients on oral or IV products, to make sure that they're having really great response and tolerating the medication and able to even obtain the medication. As Dr. Ambroz has pointed out in the beginning, the resource and getting patients to visits, it all comes full circle on the back end, not just the preventative scene. So what are, kind of thinking through, we've talked through the appropriate management steps of mild, moderate, severe, even osteomyelitis. What are some kind of clinical pearls that you want to leave the audience with about DFIs, about what are some faux pas, what should we avoid doing? If you could have one, sort of soapbox item to bring up about DFIs, like what would that be for your practice?
So it's important to remember that not every ulcer is infected. Not every ulcer needs to be treated with an antimicrobial regimen, but every ulcer needs surveillance. So what I recommend to my patients with ulcers is they regularly schedule their diabetic foot exams, their diabetic follow-ups with me at 3, 6 months, or even sooner than that. I also believe in the importance of educating the patient and the family members on the signs and symptoms that they should look for to see if their diabetic foot ulcer is becoming infected, and recognizing when this needs to be seen by primary care or their podiatrist or potentially the emergency department, and escalating their care. I regularly see patients that come in and they're using topical antibiotics. They're applied to their feet, to their dressings, and the data just isn't there to support this use. Also, the data is not present at the time for the hyperbaric oxygen therapy or the bacteriophage therapy.
Those are some really awesome points about, some misnomers, like topical, like what's readily accessible to patients. And, that might be a sign in itself that this might need attention. If your patient comes in and it's like, I'm, slathering myself in topical antibiotic products, like, okay, well, what's going on that we need to actually address? I think some really awesome takeaways from today's discussion about systematically taking the approach to, not just screen your patients and ensure that they are getting good foot exams and have really healthy hygiene for before ulcers develop, but also monitoring, managing ulcers before they become infected. And the guidelines have really great approaches to classifying diabetic foot infections when we ultimately meet that endpoint. We talked a lot about some really great opportunities for being good stewards of culture obtainment, the right test, the probe to bone test. Dr. Fidler really pointed out some really great options and when to utilize that test and how to, kind of do the initial workup on the outpatient side, which is, I think, very valuable to a lot of primary care providers. And that, the duration is a sliding scale of for antimicrobial therapy in these patients, and sometimes with adequate surgical management, resection, we can get away with a very few days of antimicrobials, potentially 48 hours worth of antimicrobials, even after full-on resective measures, if there's no residual soft tissue involvement. So with that, I want to wrap up today's discussion. I really want to thank our panel of guests today and offering their expertise. It's been a very insightful conversation, getting to look through each of your lenses when interacting with patients that have this disease state. As always, our clinical guidelines are available on the Carilion Clinic Ambulatory Stewardship website, carilionclinic.org/antimicrobial-stewardship. And also a plug for the recently launched mobile app, the Antimicrobial Stewardship app. We'll link a job aid for Carilion Clinic providers and clinicians to be able to get that set up and running, to give the resources at their fingertips, which we're very excited to see come to fruition. And again, huge thanks to podcast guests, and we will see you on the next one.